Colleagues, welcome to HHS, Health and Human Services Subcommittee. We're going to have 3 agency report outs today. We're going to have Department of Human Services Child Support Administration. We'll also have Maryland Institute of Emergency Medical Services Systems, and we'll also have Maryland Health Benefit Exchange. At this moment, I'd like to call up Ms. Natalie Andrade to read out the agency report for the Child Support Administration.
Thank you, Mr. Chair. Good morning. My name is Natalie Andrade, and I'm here with the Department of Legislative Services to present the fiscal 25 allowance for the Department of Human Services Child Support Administration. On the first page of this analysis, you can see that the fiscal 25 budget increases by $5.4 million to $110.8 million. The fiscal 25 allowance reflects a significant shift in funds. Federal funds increased by $15 million, which is coupled with a decrease of $10 million in special funds, mainly related to the Child Support Reinvestment Fund not being budgeted in fiscal 25. Exhibit 1 on page 3 shows the breakdown of the fiscal 25 allowance. As you can see, 57% of the budget goes to personnel, which is primarily to support the operation of local offices responsible for administering child support services. 20% of the budget goes to the cooperative reimbursement agreements, and 7% of the budget goes to the Baltimore City privatization contract, which is related to the child support services in Baltimore City. Exhibit 2 on pages 4 and 5 shows the proposed budget changes. And the principal factor influencing the $5.4 million increase is increases in personal expenditures. As you can see, there's an increase of $3.2 million in salary increases and associated fringe benefits. And also we have an increase of $2.6 million in the cooperative reimbursement agreement, which is attributed to higher salaries and cost of living adjustment for personnel involved in providing child support services under these agreements. On page 5, there is a discussion about the Child Support Reinvestment Fund. This fund is a special fund comprised of federal incentive payments allocated to states based on performance against 5 measures set by the U.S. Department of Health and Human Services. These 5 areas are the establishment of child support orders, establishment of paternity, collection of current support due, collection on arrears, and cost effectiveness of state services. Exhibit 3 on page 6 shows the Child Support Reinvestment Fund expenditures. And as you can see, revenues and expenditures both have shown a steady growth over the past years. And the governor's budget books estimate $18.4 million in revenue for fiscal 24. And the fiscal 24 working appropriation also includes expenditures of $16.1 million. The fiscal 25 allowance does not include funding from this source, despite the department anticipating receipt of $10.9 million according to the governor's budget books. So DHS should comment on why no funds from the Child Support Reinvestment Fund are included in the fiscal 25 allowance. In addition, the Department of Legislative Services recommends reducing general and federal funds budgeted in the State Office of Child Support Administration, which can be replaced by funds from the Child Support Reinvestment Fund. On page 7, on the personnel section, you can see that as of December 23, the vacancy rate was 7.8% or 51.5 vacancies, of which 45.5 of them have been vacant for less than a year, and 6 positions have been vacant for over a year. Compared to the number of vacancies as of December 22, the vacancies as of December 23 have decreased from 85.5 vacancies to 51.5 vacancies, indicated the concerted efforts of DHS to address the staffing needs and fill these positions. Committee narrative in the 23 Joint Chairman's report requested that DHS submit a report on positions that have been vacant for over a year as of December 22. In this report, the DHS indicated that 7 out of 8 longest-standing vacancies were filled. And additionally, Child Support Administration filled 94 positions despite 71 new vacancies, resulting in a net gain of 23 filled positions. On page 8 begins a discussion about the child support performance. And on Exhibit 4 shows the statewide performance and goals. And as you can see, the cases with support orders have remained relatively consistent with the same performance in the previous year. And performance have declined in 3 areas related to the paternity establishment, current support collections, and cases paying arrears. And none of these performance metrics met the state goals for fiscal 23, which are represented by the red marks in the exhibit. Exhibit 5 on page 9 shows the statewide performance goals for the first federal fiscal 2024, that is October to December 2023. And as you can see, child support orders nearly approach the target of 87.13%. And performance concerning paternity establishment, current support collections, and cases paying arrears all lag behind the state fiscal 24 benchmarks. Here it's important to note that this data point is a cumulative measure that increases throughout the year, and this quarter, the first quarter, is expected to be low. Exhibit 6 on page 10 shows the collection on current and overdue support. And as you can see, between federal fiscal 20 and fiscal 23, there was a decline in total collection on current and overdue support, decreasing from 583 million in federal fiscal 20 to 485 million in federal fiscal 23. This is a reduction of $125 million. So DHS should discuss effort that it is making to increase collections, particularly on current support owed. Also, DLS recommends adopting committee narrative, requesting periodic reports on Child Support Administration performance against the federal incentive objectives, and utilization of the new child support management system. The second observation is related to the child support management system on page 11. And this system or application supports the statewide child support business functions. While the intent of the new system is to facilitate the administration process, current challenges prevent the system to fully realize its potential to support program integration. Among the challenges that the agency have encountered are system integration, limited information accessibility, duplication of individual reference numbers, which poses significant challenges for child support workers in assisting customers and addressing case concerns. And finally, difficult access to the MDFIN portal. Finally, on page 12, there is a list of the tasks that DHS has identified that have been streamlined and made more efficient by the system. And also here we have priorities that will be addressed during the first quarter of 2024. So DHS should provide an update on the status of these priorities and offer an estimated timeline for fully addressing these challenges. And with that, I conclude my presentation, and I'm happy to answer any questions.
Thank you. Seeing no questions, we'll bring up the agency. Secretary Lopez.
Good afternoon, Chair McCray and honorable members of the committee. I'm Rafael Lopez, and I serve as the Secretary of the Department of Human Services. We're grateful to the governor, the legislature, the various departments and analysts who have supported us, and all of the team behind me here who represents Child Support Administration and senior leadership of our department. To my right, I'm joined by our Principal Deputy Secretary, Connie to my right, White to my right, and to my left, Carol Resnick, our Acting Chief Financial Officer. We'd like to take a few minutes just to walk you through a couple of pieces of the Child Support Administration budget that we think are worthy of bringing to your attention. First, just generally, the Child Support Administration accounts for 2.7% of the department's overall $4.1 billion budget. CSA provides comprehensive child support services to approximately 106,000 children involved in an active child support case across the state of Maryland. This work helps make it possible for us to deliver on Governor Moore's vision of ending childhood poverty in Maryland. And we're doing that by making sure we're working with both parents to provide the financial, medical, and emotional support their children need to grow and thrive. CSA's investment in children's family connections and family economic security can break the cycle of poverty by helping parents raise children with a strong foundation. Last federal fiscal year, DHS collected and distributed $431 million in child support payments benefiting Maryland's families. And of that amount collected and distributed, families previously participating in the Temporary Cash Assistance Program, or TCA, took home $63 million last federal fiscal year, providing a base level of financial stability for children. While this is a start, we can and must do more to make child support work for families, starting with improving our customer service and making sure MD-Think works well. So I want to highlight those two areas for you right now. First, on the issue of customer service challenges. The governor challenged the entire cabinet to reduce vacancies across the department. We did just that. Overall, we began in January of 2023 with a 15.2 vacancy rate. By December 31st of last year, we brought that down to 9.7%. Bless you, Senator. Which is a reduction, and bless you once again. And so we reduced our overall vacancy rate by 5.5%. To highlight our intentionality of customer service facing positions, I want to highlight that vacancy rate reduction at CSA. We're pleased to share that since January of last year, we had a net increase of 43 new child support specialists and supervisors join us across the state, reducing our program vacancy rate by nearly 10%, from 17.49% to 7.8%. Each day, we receive complaints from customers in all 24 jurisdictions about the challenges they face interacting with us. So this investment in our people, investment in reducing vacancies will help turn around this customer service culture challenge that we have across the department. Custodial parents often call our local jurisdiction offices. They call for basic things like understanding the status of their receiving their payments, their child support payments if they happen to be the custodial parent, or if they're a non-custodial parent, wondering why it is that their payment hasn't been posted when they try to access the system themselves. And that's clearly unacceptable to all of us. So we must get payments in bank accounts of custodial parents quickly and seamlessly, and we're working to do just that. We must work even more closely with non-custodial parents who have challenges making those payments. And we'll talk more about that just momentarily. The good news is that we're listening to the people we serve. We're responding with a new sense of urgency and holding ourselves accountable for following through in new ways. We have challenged our team members across the state and stressed the importance of treating the Marylanders we serve with respect and dignity. We're reminding each other to act with urgency, to resolve issues, and to challenge the status quo all around us. And we're working daily to improve customer service. We've already seen improvements in our responsiveness across the state. This summer, we will launch a new statewide customer service call center that is far more responsive to our customers in real time. We intend to fully integrate the local departments of social services into a new customer relationship management system, or CRM, with world-class standards and accountability. These are just the baseline efforts that we're making, and we must ultimately use these efforts to create a workplace culture where world-class customer service is the new normal at DHS across the state. Marylanders deserve nothing less. Second item we'd like to bring to your attention is our challenges this year with information systems and what we're doing about them to course correct them. This committee clearly has been acquainted with us sitting before you and testifying around how we're working to invest in MD-Think. Specifically within the Child Support Administration, CSMS, which is the application that all of our team members and our customers are part of, is the otherwise known as the Child Support Management System. And we continue to experience far too many issues that we inherited, but are proactively working to correct them. The challenges that the system and the application have presented statewide, I've heard and we've heard from all 24 jurisdictions, from all of our staff across the state, and it impacts the way our customers experience the child support interaction, specifically when they're working with the MD-Think consumer portal. We're listening to our customers, but we're also listening to our team members across the state and responding directly with them, engaging them and helping generate new solutions. Over the last 9 months, we've identified and prioritized system fixes for CSMS to ensure that the system works for our team members who use it every single day just to do their jobs. We've improved timeliness and accuracy of child support payment disbursements, which is still a work in progress, but we're actually making progress there. And we actually hired a new child support management system application director at MD Think, already working in stronger partnership with our 24 local jurisdictions and actually asking them for their input in the application redesign. This work is just the beginning, and it's important that the public and our team members understand that we hear you and we are moving with urgency to course correct. The last item we want to bring to your attention has to do with really turning around a department-wide culture around making sure we're working for families, not the other way around, and navigating our bureaucracy. First, we'll be using the Child Support Reinvestment Fund as federally intended to expand programs and services for helping Marylanders. Maryland earns federal reinvestment fund dollars based on the program's performance on key federal indicators. For far too long, DHS has used that Child Support Reinvestment Fund to pay for CSA operational expenses, and we will not do that continuing forward. This administration will be data-driven and heart-led and will use the incentive funds as they were intended, which is to expand programs, increase our outreach across the state, and strengthen community partnerships to make the Child Support Administration work more seamlessly for families, not the other way around. 9 months ago, we began seizing opportunities to strengthen partnerships with key stakeholders and will convene a new Child Support Advisory Committee with the Maryland Judicial Council, child support attorneys, and community-based organizations to support families and expand our outreach to strengthen Maryland's child support system. We understand fundamentally that there's a difference between those parents who choose not to pay and those who are unable to pay child support. And we want to make sure that we're treating everyone with respect and dignity as we figure this out and move child support administration forward. So we're continuing to fund and enhance existing programs while actively seeking more opportunities for new parenting and employment programs to assist non-custodial parents who need additional skills and employment opportunities to ultimately financially and emotionally support their children. Bottom line, we understand barriers that we've created with ineffective information systems and poor customer service can impede progress toward our vision of a child support administration that fosters family connections, but we want to make sure that children have the financial and emotional foundation they need to thrive, not just in their own family, but in neighborhoods and communities. Our investments in our team members, in CSMS, in our strengthened community partnerships, and our programs are designed to course correct this moving forward. With that said, this budget proposal was designed with many of you in partnership and our team members across the state and organizations. We stand ready to work with you on bold solutions to do this in a fiscally responsible way. And with that said, I'll turn it over to our Acting Chief Financial Officer, Kirill Resnick, who will answer some of the questions that our DLS team members have asked of us.
Thank you. Thank you, Mr. Secretary. Thank you to the chair and the subcommittee. I will briefly summarize our answers as previously stated. There's much more detail in our response that I encourage you to look at. To question number one about why we should comment about why the child support reinvestment funds were not included in 25 allowance, and respond to the DLS recommendation about supplanting general and federal funds with the reinvestment fund incentive money. Previously, employed DHS budget staff inadvertently left off child support reinvestment funding off of our FY25 budget submission. We will work with DBM and DLS to correct that oversight once we're informed by the Administration for Children and Families as to what our annual allocation for the reinvestment fund is. However, we do respectfully disagree with the reduction of general and federal funds to be replaced by the reinvestment fund dollars. We believe that this is contrary to the federal purposes outlined by ACF, and as indicated by the Secretary just moments ago, we do have plans for how that money should be used to enhance our programs rather than to supplant them. To question two, asking us to discuss the efforts we're making to increase collections. DHS concurs with the recommendation to provide periodic reports and will provide those reports outlining how we're seeking to increase collections, particularly current support through several efforts, including building and renewing trust, increasing strategic partnerships, and improving the child support management system in MD Think. Details for how we're implementing these efforts are laid out in detail for you in our written testimony. For question three, asking us to provide an update on the status of priorities and offer an estimated timeline for when we're meeting the challenges outlined. Priorities addressed during the first quarter 2024 are expected to be completed by end of March. While
any additional work identified during the development may occur during that second quarter. We're including the details of those updates in our first quarter priorities in the written testimony, including data reconciliation between the three main applications of MD Think, payment summary and visibility in CSMS, and modifications for supporting orders in CSMS with additional fixes as necessary. Again, much more detail provided in our submission. As to the two recommendations, including language reducing general and federal funds, as indicated, we oppose that because we believe that it violates the Social Security Act intent. And as to the adding narrative to provide additional child support performance reports, we fully concur with that recommendation. I'm more than happy to provide that data and reports. So with that, thank you very much. We're happy to take any questions, and we encourage you to support the governor's allowance.
Thank you, Mr. Secretary, and thank you to your team. Just one, it's not a question, it's if you can get it back to Ms. Andrade, specifically to the Baltimore City child support. If the new vendor is the same vendor, or if there's a new vendor, could you just let her know?
Certainly.
And also the federal incentive performance goals, they weren't whoever the previous vendor wasn't meeting those. Could you just let us know how did they do this year? And if you can get that to Ms. Andrade, that would be helpful. Yes, sir. Senator Hedelman.
Thank you very much, Mr. Chairman. I have a question for you, and thank you for your presentation. In the first response to DLS, talking about the Child Support Reinvestment Fund, this is not a new fund, correct? This has been around in years past. So how was it treated in prior?
Sure. Happy to speak to that. And actually, ACF is my old office in the federal government, so I know this quite well. As my colleague Kevin Geiswhite, who will say when I ask a very simple question, which is, how do we invest Maryland's incentive money? The answer was we don't. And when I asked why, it was because we were using it for general operational purposes for years, which is not the intent of the money from the federal government at all. The intent is to actually build things like community partnerships, to actually strengthen how we engage parents on everything from trying new pilots and testing out innovative ideas on things like how to engage non-custodial parents in new ways, how to test out new ideas, perhaps even in MD Think, how to test out ideas that our staff have, our team members across the state. That is the intent of the federal incentive fund. And so it was not, in my opinion, being used for its original intent. And I won't do that as secretary of this department. I will use the federal funding to invest the way it should be, and to partner with all 24 jurisdictions and our community-based organizations to find new ways to expand and strengthen our outreach with parents and families.
So I appreciate that,
Sure.
Mr. Secretary. But that does require additional funding to replace those funds. Is that correct?
It does not.
It does not.
So the general and federal funds that the recommendation is to replace are already budgeted. So these come in as special funds.
Okay.
Even though they're federal, I know it's a little confusing. They come in federally from the federal government, but we account for them as special funds and should be used separately. So right now, the state and federal money that we are asking to be kept is budgeted in the governor's allowance. So this comes in as extra dollars.
Gotcha. Okay. Thank you.
Certainly. I will add, though, I'm glad you asked the question, Senator. One could argue that Maryland could place itself in financial jeopardy by being penalized for improperly using the funds. And so one of the things we're trying to do is make sure we're not in that position moving forward. And so, and being very diligent about how we're using those funds, both in terms of the incentives, but also how we are clear about the separation of operational dollars from the state general fund and federal dollars.
Okay. Thank you.
Seeing no further questions, just wanted to say thank you for your service, Ms. Andrade. Just thank you for everything you do in reference to helping us make sure that we understand the respective agency, and look forward to the responses back to
Absolutely.
the
Happy to do so.
analysts. Thank you.
Thank you all.
Colleagues, at this time, we're going to turn our attention to the Maryland Institute for Emergency Medical Services System, and we'll have Ms. Naomi Kamara.
Good afternoon. My name is Naomi Camaro. I'm a budget analyst with the Department of Legislative Services, and I'll be presenting the DLS analysis on the Maryland Institute of Emergency Medical Services Systems, or MIMS. On the first page, it shows the budget for MIMS in fiscal 2023, fiscal 24, and 25. The fiscal 25 allowance includes $22.5 million for MIMS, which is a decrease of $25.1 million from the fiscal 24 working appropriation, mainly due to an enhancement that was included in the fiscal 24 appropriation of $25.5 million to address insolvency issues in the Maryland Emergency Medical System Operations Fund, or MIMSOF, and provide additional grant funding for the R. Adams Cowley Shock Trauma Center. In fiscal 2023, MIMS canceled more than $2.2 million. $1.8 million of this was due to the anticipated need for increased pediatric care capacity at the Critical Care Coordination Center. MIMS anticipated a seasonal surge in pediatric respiratory infections, and this funding was authorized by budget amendment from the Office of Preparedness and Response. That anticipated need did not arise, and so MIMS ended up canceling the funding. DLS has asked MIMS to comment on its efforts to continue the Critical Care Coordination Center and its plans for the facility in the future. On page 3, Exhibit 1 shows the breakout of funding for MIMS in fiscal 2025. The majority of funding, nearly 3/4 of the budget, is allocated to personnel costs. And there's also about $2.8 million for telecommunications and IT expenses to support MIMS's communication infrastructure, and smaller amounts of funding directed toward grants to local jurisdictions. On pages 4 and 5, we've broken out the major changes in the budget from fiscal 24 to 25. Again, the change driving that $25 million decrease is the enhancement to MIMSOF authorized in fiscal 2024. But some of the smaller differences include increases in personnel costs, as well as some smaller decreases in grant funding for naloxone procurement, as well as decreases in telecommunications expenses. DLS has asked MIMS to provide brief explanations for those decreases. On page 6, we have included personnel data for the agency. MIMS is adding 2 new positions in fiscal 25, which were both created by contractual conversion. And so these roles were already filled as of this writing in January of this year. I'll briefly mention vacancies as well. So as of December 31st, 2023, MIMS had 13 vacancies. 4 of those had been vacant for 1 year or more. And so we've asked MIMS to comment on its efforts and recruitment activities to fill those long-term vacancies. On page 7, we've observed that the Commission to Study Trauma Center funding is co-staffed by MIMS and the Maryland Healthcare Commission. This commission was established by legislation in 2023. MIMS oversees the designation of hospitals as trauma centers across the state, and those are listed out in Exhibit 3 on pages 7 and 8. The commission was established to examine funding sources for the Maryland trauma system to ensure that trauma centers have sufficient funding to support their workforce and operations. They met 5 times in calendar 2023, and since the writing of this report has released their own report with their findings and recommendations. Some of the recommendations that are included in the report are to improve data systems to enable linking the MIMS Trauma Registry, the HSCRC Hospital Dataset, and the Maryland Healthcare Commission All-Payer Claims Database, as well as evaluating the use of trauma quality measures as a factor in awarding funding to trauma centers. These 2 recommendations are related to MIMS work, and so we've asked MIMS to provide an update on its progress to date to implement those 2 recommendations. In closing, DLS recommends concurring with the governor's allowance for MIMS, and I'd be happy to take any questions that you have.
Seeing no questions, we can call up the agency.
Good afternoon, Mr. Chair, members of the subcommittee. I'm Dr. Ted Delbridge. I'm the Executive Director for MEMS, or the Maryland Institute for Emergency Medical Services Systems. And I realize you have what we've submitted in writing, and so I'll try not to be redundant and too wordy.
And just the FYI, we don't have what you submitted in writing.
Okay, well then I'll be more wordy and less redundant.
And submit in writing, please.
And
State Police.
for sure, absolutely. So the Maryland Institute of Emergency Medical Services Systems is an independent state agency that coordinates all the components of the statewide EMS system. We do that by way of providing medical oversight, promulgating statewide clinical protocols, so that a person who summons EMS in one part of the state is subject to the same sort of treatment that they would get in a different part of the state. By maintaining and operating a statewide communication system such that a paramedic in the field can talk to any hospital in the state, a base station physician, to get clinical guidance or help them manage a more complex case, and in many times determine what the appropriate destination for the patient is. By designated trauma and specialty centers, 10 trauma centers inside the state of Maryland, more than 24 cardiac intervention centers, 30 some stroke centers, and level 4 perinatal centers. And licensing and regulating commercial ambulance services, and licensing or certifying EMS clinicians, emergency medical dispatchers, emergency medical responders, emergency medical technicians and paramedics, nearly 20,000 of those. We appreciate the opportunity to discuss our budget. We appreciate the analysis by Naomi Camero, and also the help we get from our DBM budget analyst, Christina Jorge-Tuñon. And of course, we concur with the DLS analyst recommendations. I'll talk for a moment about overdose response. Naomi mentioned that we previously received grants from what was then the Opioid Operation Command Center to pass through to local jurisdictions to help them supplement or offset their costs to provide naloxone to patients they treated in the field and didn't subsequently transport to the hospital. What is now the Office of Overdose Response has changed tax a bit, and the grant money that we previously obtained is no longer available as they are off on a different strategic initiatives. But we continue to participate extensively in the overdose response of the state. We provide data weekly to MDH and the Office of Overdose Response in terms of the doses of naloxone that are given by the EMS system throughout the state, and break it down by jurisdiction. We provide near real-time data to the high-intensity drug trafficking area OD map that alerts law enforcement to pockets of overdose activity so that they can respond appropriately. And we are working with CRISP, the Chesapeake Regional Information System for our patients, and the Department of Health to develop a new dashboard that will be useful to local health departments as they track overdose activity within their jurisdictions. Naomi mentioned the Critical Care Coordination Center. That was something we developed in the late fall of 2020 in response to the COVID pandemic. We realized that patients were, for lack of a better term, stuck in hospital emergency departments needing critical care with no resources available in the particular facility they were in, and a lack of visibility to where critical care resources might be available in the state. So the Critical Care Coordination Center serves as sort of an information clearinghouse for those events, so that the people taking care of a sick person in a hospital emergency department can go about the business of taking care of the sick person and not worried about the logistics of how to get that person to the care they need, making multiple phone calls. We do this with a critical care coordinator who's generally a paramedic and an on-call intensivist and an intensive care physician who provides real-time guidance to the people taking care of the patient where he or she is, as we find adequate resources to care for the person someplace else. To date, we've fielded more than 6,800 calls from Maryland hospitals to help with that planning. It's interesting to note that approximately 30% of the calls that we field end up in no transfer happening with the help of the intensivist who's on call. We can temporize things and get the patient over the hump so that there's no need to transfer him or her anywhere. In the fall of 2022, we were faced with a triple demic, if you will, that involved pediatric patients. It's noteworthy that approximately 40% of Maryland's hospitals have no capacity to take care of a child inside the hospital, beyond the emergency department. And as there was a rush in cases with RSV and influenza, there was concern that that would carry on for months and overwhelm the healthcare system for a longer period of time. We prepared to manage that by expanding the role of the C4 to include pediatric patients and anticipated that we would have that need throughout the springtime. That ended up resolving sooner than we were worried that it would not. And so the model for the C4 is to expand its services and contract it in response to demand, which generally is seasonal. And when we contracted, we saved money. That money was reverted back to MDH, who was the middle person for a federal grant that made it possible. And that is how we're operating the C4 today, is through a no-cost extension based on money we saved last fiscal year. With regard to the C4's future, that's still undetermined. Grant funding runs out at the end of June. We're working with MDH to identify additional grant money if it's available, or with Maryland's hospitals to support it, or it will essentially go away at the end of June. We are in the middle of a telecommunications upgrade. I mentioned that one of our roles is to manage a really advanced telecommunication system that allows EMS personnel in any part of the state to talk to an EMS base station any place else in the state, and in times conference folks in. It's operating with 1970s era analog equipment. We're in the process of upgrading that and have been for the past few years. That work continues. Our ability to manipulate budget money and reduce the telecommunications expense has to do with maintenance funds that were not yet needed, as we're still in the middle of purchasing and upgrading the equipment that we have. But we'll have to reallocate that money back to the telecommunications maintenance once the project is complete. We're at a phase right now where we're ready to do, or almost ready to do, parallel operations using the old technology and the new technology in parallel with each other to prove that it's fully operational in part of the state as we continue to make the upgrade enhancements that are necessary. With regard to position vacancies, I think we're down to 4. The ones that Naomi pointed out that have been there for a year or more are all pending offers that are currently out. So we are resolving that we typically have challenges in communications engineering and IT where folks can make a lot more money in the private sector than they can in our shop. And we continue to work on that, but we're making excellent progress. We participated on the Commission to Study Trauma Center funding this past year. The report was finalized just in the past couple of weeks. There are 2 roles for MEMS upcoming. One has to do with linking the data from the trauma registry that we manage to financial data from the HSCRC and the Healthcare Commission. What was challenging for the Commission was linking the financial aspects of patients' care with their clinical aspects because those 2 data systems don't communicate with one another, and we'll work on that. And the other has to do with creating a statewide trauma system report card so that people can be comfortable that the investment they're making in the trauma system is worthwhile. And I'll finish by saying we're keenly aware of emergency department operations and ED wait times, and we also participated on a panel this past year that was coordinated by the Maryland Hospital Association to help identify causes of prolonged emergency department lengths of stay and provide ideas for improvements. That report is still in the works and will hopefully come out in the days upcoming. We look forward to continuing our work in that regard. And I'll stop talking and I'm happy to try to answer any questions.
And thank you. Obviously, we know that the 4 positions you said you were working on and that they've been vacant for longer than a year, but is it 1 year to 2 years or?
14 months.
14 months for the full positions, each one of them,
Well, 14 months is the general
average.
thing.
Okay.
I'm thinking about one in particular that's been 14 months due to retirement that hasn't been filled yet. The IT positions resulted from a changeover of IT staff about the same time frame.
Got it. So going back to the critical care condition center, C4 centers, so I got to listen because I don't have anything to read off of. So it sounds like the need was still there. You all were able to supplement that with federal funds, which is why the state funds was reverted back. And you all are going to seek out other federal funds or other grant funding, I guess, in June or July. And the need is still there?
The need is, it's really fairly seasonal. So let me explain, make sure I said this the right way. The C4 was initially stood up on the basis of federal grant money that was available to MDH that they allocated to MEMS. That is how the C4 has been operating since its inception in November 30th, 2020. The money that was reverted was grant money that was provided by MDH through the Office of Preparedness and Response to MEMS that we didn't use and went back to MDH. And then MDH essentially provided us the ability through its arrangement with the CDC to continue with a no-cost extension. And those are the funds that we're operating on with now. The need has been there throughout this past winter as Maryland Hospitals experienced a surge of RSV influenza cases and a small increase in COVID-19 cases. If this year is like the past year, the need will attenuate a whole lot over the course of the summer months and pick up again in the fall. And we will contract the model by which we provide services during that same period of time.
Got it. Obviously, we all know the importance of what's going on with overdoses at the moment, and I'm glad with your partnership with the respective local jurisdictions. If you can get the written response back to Ms. Kamara, I just want to dig into it just to better understand. I heard you explain it, but I just want to make sure that I'm reading it too, so that I'm just capturing it.
Sure.
Seeing no further questions from the committee members, just want to say thank you for your leadership, especially during the times when we need it the most. And Ms. Kamara, thank you as always for helping us understand what's going on with the respective agency. Colleagues, we'll turn our attention to the third and final agency, that is the Maryland Health Benefit Exchange. And at that time, we'll hear the report out from Ms. Victoria Martinez.
Thank you, Mr. Chair and members of the committee. My name is Victoria Martinez, and I'm with the Department of Legislative Services. Today, I'll be presenting on the Maryland Health Benefit Exchange analysis. The Maryland Health Benefit Exchange provides a marketplace for individuals and small businesses to access affordable or no-cost health coverage. As you can see on the first page of the analysis, the fiscal 2025 allowance increases by $34.9 million, or 5.6%, for a total of $658 million. As shown in Exhibit 1 on page 2, most of the agency's funding, about 83%, goes towards reinsurance payments, while an additional 3% goes towards the Young Adult Subsidy Program. The remainder of the budget is allocated towards information technology and administration expenses, with about 7% for each. Exhibit 2 on page 3 shows the breakdown of the IT and administration expenses. The biggest IT expenses include $15.3 million for maintenance and system support and $13.8 million for the Maryland Health Connection enhancements. The largest administrative expenses include 12.8 million for the call center, 10.6 million for personnel, and 10 million for connector entities. Exhibit 3 on page 4 shows the breakdown of the 34.9 million increase, with the largest changes being within the reinsurance program, with a 24 million increase for reinsurance payments and 10 million for the young adult subsidy program. Aside from the reinsurance program, there was limited overall change. There were various changes for IT independent contractors and other IT services, with the largest change being a 2.9 million increase for IT consultants to develop enhancements for the MHC website. Within the administration program, the largest change is a 3.2 million decrease in call center cost to assist individuals enroll in health insurance. In terms of personnel, as shown on page 6, there are 6 additional regular positions in the allowance for a total of 73 positions. The agency has a vacancy rate of 2.99% and is below the number of positions needed to meet the budgeted turnover expectancy in fiscal 2025. The first key observation on page 7 discusses the reinsurance program and forecasted funding. The state reinsurance program was established in 2018 to address rising health insurance premiums in the state. MHB was required to apply for a state innovation waiver that would allow them to seek federal pass-through funding to support that program. The federal government approved the waiver in 2018, and MHBE recently submitted a request for an extension of the waiver, which was also approved, and the waiver period is valid from January 1st, 2024 through December 31st, 2028. Exhibit 4 on page 8 shows sample monthly premiums for a 40-year-old in a Care First Blue Choice plan, showing that individual market rates for bronze and gold plans increased from fiscal 2023 to 2024, while the silver plan remains stable. Despite the increases from 2020 to 2024, sample monthly premiums for all 3 plans remain significantly lower than prior to the program's implementation in 2019. Exhibit 5 on page 9 shows the actual and estimated reinsurance costs and federal pass-through allotment from 2019 through 2028. In a previous projection, MHB indicated that the available federal funds plus the state reinsurance fee would have been insufficient to support the program through 2028. However, in an updated forecast, MHB anticipates sufficient funding to support the program. The improved forecast is primarily due to lower than expected average reinsurance claim amounts, lower than expected program costs, and higher than expected federal funding. The second key observation on page 11 discusses the young adult subsidy program. Chapters 778 and 777 created the state-based young adult health insurance subsidies pilot program for 2 years for 2022 and 2023. And chapters 256 and 257 extended the program through 2025. As shown in Exhibit 7, MHB experienced significant increases in all age group categories enrolled in a qualified health plan, with the biggest increases being 51.8% in the 18 through 25 age group and 21.7% in the under 18 age group. All other age group categories showed increases ranging from 10.7% to 17%. For comparison, the largest increase from 2022 to 2023 was a 7% increase in the under 18 age group. Key observation 3 on page 12 discusses the increase in enrollment in a qualified health plan through the Maryland Health Connection. As shown in Exhibit 8, MHBE saw a 17% increase in enrollment from 2023 to 2024, with a total of 213,895 in 2024. The red line shows the rate of uninsured Marylanders, which has been stable at 6%. And moving on to the last key observation starting on page 13, this discusses Medicaid unwinding and redetermination, which is one contributing factor to the significant growth in enrollment, as individuals that no longer qualify for Medicaid may seek a qualified health plan through MHBE. Beginning in April 2023, federal law required states to resume measures to verify eligibility information and allowed states to begin ending coverage for participants ineligible for Medicaid. There was a total of 161,659 participants up for renewal on December 31st, 2023. And Exhibit 9 on page 14 shows the outcome of these Medicaid redeterminations. Of these redeterminations, the majority, 60%, received coverage extensions, while 36% were disenrolled and 4% were pending reviews. Of the total coverage extensions, 85% were participants who were auto-renewed. And of the total disenrollments, the vast majority, 88%, were procedural terminations, which are participants disenrolled due to failure to submit a timely application or because the renewal was incomplete. So only 12% of disenrollments were participants who were disenrolled specifically due to ineligibility. Exhibit 10 on page 15 shows the number of individuals who enrolled in a qualified health plan who were previously enrolled in Medicaid, with a 375% increase from 2,966 individuals in 2023 to 14,089 in 2024. DLS asked that MHB discuss whether they anticipate additional growth in individuals enrolling in a qualified health plan due to Medicaid unwinding and other factors leading to high growth. Finally, on page 16 is our recommendation, which is annual language requesting a report on the reinsurance program costs and forecast. That concludes my presentation, and I'm happy to take any questions.
Thank you, Ms. Martinez. And seeing no questions at this moment, we'll bring up the agency.
Good afternoon, Chair McCray and Senators Hellman and Zucker. I'm Michelle Eberly. I'm the Executive Director for Maryland Health Benefit Exchange, and I have with me Tony Armiger, who's our Chief Financial Officer. We are happy to be here today to discuss our budget, and we thank Victoria Martinez immensely for her review and for her recommendations and the work that she has done. We've had another banner year with the exchange. We saw double-digit growth in all of our enrollments this past year. In fact, new enrollments were up 64%. Our young adult program, which is where we focused on to try and get younger, healthier people into the marketplace, was up 41%. Our three areas, actually two areas that we focused on, two other areas, our Black and Hispanic populations. Our Black enrollments were up 33%. Young adult Black enrollments were up 46%. Our Hispanic enrollments were up 30%, and our young adults in the Hispanic community were up 50%. So these are all communities that we've been really focused on outreaching to, and through all of our technology that we have, our consumer assistance channels, our producers around the state, we just had a phenomenal year. What also contributed to that is the public health emergency unwinding. So we know that we had several years where folks stayed on Medicaid. This year, they are, of course, rolling off of Medicaid. We're very fortunate in the state of Maryland that we are one of 4 states that have an integrated eligibility and enrollment system, meaning that when we built the exchange, we built it so that anyone can come through, and we will determine if you're eligible for Medicaid or eligible for commercial assistance. What we did, again, using our technology this year, was implement a program where if you were over scale for Medicaid and you're going to be terminated, we automatically enrolled you into a commercial plan with the same carrier that you had in the MCO. Fortunately, all of our carriers in the MCO also are in the commercial market. Now, you still had to take action and say, I want that plan and pay that first month's premium. But what that resulted in that and a lot of other efforts is that Maryland is one of the top 5 states in the nation that have retained people in coverage that have been lost from Medicaid. So a huge success. What I want to just address in terms of, well, I'm going to back up for a moment. We did bring with you, and you probably already got our annual report from last year. So this is a real good synopsis of everything that we accomplished last year. Before I move into responding directly to the question, I like to make legislators aware that on marylandhbe.com, which is our stakeholder site, we have data reporting there. We update it every single month. It has very specific information about who's enrolled, demographics, the plans that they're enrolled in, our consumer assistance channels. So that's out there for your use. What we did this year is we created a dashboard, and in that dashboard, we have it sorted by legislative district. So if you want to see what's going on in your particular legislative district, it's out there, it's updated every month, and it gets very specific into demographic information and coverage information. So having kind of talked about the successes we've had this year, really good year, we do know that we are part of the continuum of health coverage in the bigger picture. And we want to really make sure that you're aware when you look at our budget, because it looks like a humongous budget, but the reinsurance funding is pass-through funding. None of that supports our administrative costs. It is funds that are passed on to the carriers to lower the premiums for everyone. So that's really important because it looks like a huge budget, but really we operate on our mandated $32 million and then additional general funds that we have gotten. So that's just something to keep in the back of your mind. We were asked to comment on whether we anticipate additional growth in the individual market related to the Medicaid unwinding. State of Maryland took the full year to do the unwind process. We started the end of May were the first termination. So we've got a few months left before we're through that. We do anticipate we're going to continue to have increased enrollment from that. What also became readily apparent through the public health emergency unwind, through some surveys we did, is that the exchange is now fully recognized after 10 years as the marketplace in Maryland to go and get health insurance. And even for folks that aren't eligible for tax credits, which you only can get by coming through the exchange, we're getting a lot of folks that just come through the exchange. We now, people know this is where to go. Between our producers and our consumer assistance workers, we really provide tremendous consumer support for people trying to purchase health insurance. So not only as a result of the public health emergency unwinding, but the continuation of the young adult subsidy program, again, our enrollment this year was up, as Victoria said, 17% overall, but new enrollments were 64%. We have nearly 214,000 people enrolled through the exchange in commercial business, well over 1 million in Medicaid, and in fact, 1 in 5 Marylanders come through the marketplace. So hopefully we'll continue to see that growth. And we do concur with the recommended action and ask your support for the governor's allowance.
Well, thank you, Madam Executive Director, and thank you for the work that your team is doing. I enjoyed looking through the annual report, just skimming it. I actually think I've seen some constituents' pictures in there.
Oh, good.
And just want to say thank you, Ms. Martinez, for what you're doing, just to educate us and make sure that we're knowledgeable about what the respective agency is doing. Colleagues, this ends our hearings for HHS this Friday. We do have hearings Monday, last hearing, Monday at 1 p.m. Look forward to seeing you all Monday. Y'all have a blessed day.
Thank